Welcome back to our comprehensive explainer series on ICD-10-CM Chapter 15. I'm Harshal, and today we're tackling Part 3. We're zeroing in on maternal disorders and diabetes in pregnancy. Now, if you're a medical coder or a compliance pro, you already know the drill, right? Chapter 15 requires just extreme precision. Literally, a single misplaced decimal or a missing secondary code, that's a guaranteed claim denial. So our goal today is to give you a really clear, compliance-driven framework so you can navigate these highly specific coding blocks with absolute confidence. Let's get started.
Okay, let's dive into this. Here is our roadmap for today. 1. Early complications. 2. Maternal infections. 3. Diabetes classifications. 4. Gestational rules. And 5. Clinical cases.
Section 1. Early complications and screens. Navigating the O20 to O29 block. So the O20 through O29 block is specifically reserved for early maternal disorders related to pregnancy. And getting this right completely relies on mapping the provider's exact clinical findings to the correct category. For example, say a patient presents with vaginal bleeding at 10 weeks. You can only assign O20.0 for a threatened abortion if the provider actually confirms the presence of a fetal heartbeat, usually via ultrasound. Then, for morning sickness, O21.9 captures nausea and vomiting in the first trimester, but only provided there's no severe dehydration that requires hospitalization. And what if an antenatal screening flags elevated alpha-fetal protein levels that prompt further testing? Well, that drops neatly right into the O28.3 code for abnormal fetal blood findings.
Now, if there is one recurring motif you absolutely must remember for this entire block, it's strict documentation validation. You have to firmly validate documentation for the trimester and gestational age. Whenever you use a code from the O20 to O29 series, you have a mandatory requirement to pair it with a Z3A code. That's what indicates the specific weeks of gestation. Without that Z3A code, your claim is incomplete and, honestly, non-compliant.
Section 2. Maternal infections and anesthesia. Targeted complications.
Let's see how this builds into some more targeted issues, because this brilliantly illustrates the difference in our coding focus depending on the condition. Think about the O23 subcategories for maternal UTIs. The primary driver here is the trimester, first, second, or third, and that gets paired with an additional code to identify the exact causative organism like E. coli. But then, look at the O29 category. The focus shifts entirely. This block captures systemic reactions to pain management, like anesthesia complications. So, if a patient develops a post-spinal or post-epidural headache, you're focusing on the nervous system effect rather than the trimester.
Section 3. Diabetes mellitus classifications. Mastering the O24 category.
Now, what's really interesting about this is that it's one of the most frequently tested and heavily audited categories in Chapter 15. The ICD-10-CM guidelines draw a really hard line between conditions a patient already had versus conditions caused by the pregnancy itself. So O24.0 through O24.3 strictly classify pre-existing diabetes. That means type 1, type 2, or unspecified diabetes that the patient literally had before becoming pregnant. Gestational diabetes, which only develops during the pregnancy, is isolated entirely into its own subcategory, which is O24.4.
Section 4. Gestational diabetes coding rules. Strict hierarchies.
Because gestational diabetes is managed dynamically as the pregnancy progresses, the guidelines have instituted a really strict coding hierarchy and combination treatment rules for the O24.4 category. I want you to lock this definitive override rule into your memory right now. If a patient with gestational diabetes is treated with both diet and insulin, only the code for insulin-controlled is required. You do not code diet-controlled if insulin has been introduced to the treatment plan.
Think of it as a super clean decision tree for handling combination therapies. If the documentation says diet and insulin, you bypass the diet code completely and assign O24.414 for insulin controlled. What if the patient is managing the condition with a diet plan plus oral hypoglycemic drugs? You code only for the oral medication control. Essentially, medical intervention always overrides a diet-only classification.
Furthermore, whenever you're working in the O24 category, you are rarely just assigning one single code. You have mandatory secondary codes to append. You absolutely must add the specific underlying diabetes mellitus code if it's pre-existing. If the patient is on long-term insulin, you must add Z79.4. And as always with Chapter 15, you must append the Z3A code for the exact weeks of gestation. Leaving these off your chart is for sure the fastest way to fail an audit.
Section 5. Clinical case studies. Putting knowledge into practice.
Okay,
We've covered a ton of ground, so it's time to actively test the knowledge we've just covered with a few real-world scenarios you might actually see in your next audit. Here's our first scenario. We've got a 26-year-old at 20 weeks gestation. A culture confirms an E. coli UTI. The provider clearly documents UTI, complicating pregnancy, second trimester. Take a second to think about the primary code.
Right, the correct code is O23.42. The documentation explicitly gives us two crucial pieces of data, urinary tract and second trimester. That points directly and exclusively to O23.42. And of course, keep in mind, you would also add a secondary code here to identify the E. coli organism.
Let's look at case 2. A 27-year-old on her second postpartum day complains of a severe headache that worsens when sitting upright. She had a cesarean section under spinal anesthesia, and the provider documents post-spinal anesthesia headache. So which category and code apply here?
The answer is O29.3. Remember how we compared the different focuses earlier? A post-spinal headache is medically classified as a nervous system complication resulting from anesthesia. Because it's directly tied to the pain management procedure during her delivery care, it falls perfectly into O29.3.
Now let's tackle our final, multifaceted scenario. A 30-year-old at 28 weeks gestation comes in for regular antenatal care. She has pre-existing diabetes mellitus and is currently on insulin. How do we string together the coding strategy for this encounter?
So, the crucial point is that this absolutely cannot be captured with just a single code. Your strategy requires a primary O24 code for pre-existing diabetes and pregnancy, third trimester. But you don't stop there. You must pair it with a code for the underlying diabetes mellitus type, followed by Z79.4 to indicate long-term insulin use, and finally, the Z3A code to document the 28 weeks of gestation. Building this chain of codes ensures total clinical accuracy and compliance.
As we wrap up today's explainer, I want to leave you with this. How will you implement these combination rules in your next chart audit? Understanding these hierarchies isn't just about passing a test, it's about painting a totally accurate clinical picture. Thank you for watching, and stay tuned for Part 4. This is Decode Healthcare with Harshal.